Well, hello, everybody. My name's Jason Backrack, and I'm the medical director and founding partner of North Bay Eye Associates. We're a multi-subspecialty clinical practice in Northern California, and I also run the glaucoma division with my friend George Tanaka at California Pacific Medical Center, where we train residents in the management of glaucoma. And I'm so excited to be here today. I'm joined by one of my good friends and somebody that I really look to for innovative thoughts and ideas, both on the pharmaceutical and surgical side, Dr. Constance Okeke from the Virginia Eye Consultants. And we're going to co-moderate a session going through a couple of very interesting cases and really just chewing the fat on how to manage people, how Vyzulta may fit into our management paradigms, and really just to think out loud about how we decide on therapy and where it may fit in. Before we start, I'd like to introduce Connie. And Connie, would you like to introduce yourself, and then we'll get going?
Yes, hi. Jason, it's a great honor to be here with you, a great friend and a colleague, someone I hold high esteem to with anything and everything that you do around glaucoma. I'm excited to be here. I'm coming from Norfolk, Virginia, at Virginia Eye Consultants, where I'm the lead glaucoma specialist there. I also am an assistant professor of ophthalmology at the Eastern Virginia Medical School, where we teach medical students and residents ophthalmology and do research with them. So I'm really excited to be here and talk about Vyzulta, something that I'm been using for a long time, and excited to share some of our real world experiences.
We do have some perfunctory slides that we're going to go through quickly. Both Connie and I are consultants for B&L. The contents of this deck was developed by B&L. This is not a CME event. There will be no credits, and the information is on label with the US FDA guidelines. Next. I'm just going to briefly go through the important safety information that all of us should be aware of. Vyzulta, of course, is latanoprostatine bunad, ophthalmic solution, 0.024%. It's on label for reducing IOP in patients with open-angle glaucoma or ocular hypertension. When you look at the ISI, it's essentially based on prostaglandins. There's nothing added to the ISI based on the nitric oxide component. So increased pigmentation of the iris and periorbital tissue, or PAP, the gradual change to eyelashes, including increased length, thickness, and number of eyelashes can occur. And these changes are usually reversible upon treatment discontinuation. Obviously, we're going to use it in caution in people with iritis or uveitis, and it should not be used in people with active intraocular inflammation. Next. Any type of inflammation, such as macular edema or CME in the retina, has been reported with prostaglandins, as all of us know, and you'd want to use it in caution in people that were at high risk for that, like aphakics, a torn PC, or people that had increased risk for macular edema. All drops, of course, on label have the risk of bacterial keratitis. So you want to be careful in how patients handle their drops. And of course, you want contact lenses out prior to application and time before reinsertion. The recommendation is 15 minutes. There have been some adverse events reported, although, as we know, Vyzulta is a very well-tolerated drop, but there has been conjunctival hyperemia, eye irritation, eye pain, and installation site pain reported during the clinical trials that I was honored to be part of. Next. So why don't we start with the case number one, and right out of the gate, we're gonna start with something interesting, a normal tension glaucoma case. All of us have NTG in our practice if we're managing glaucoma. I practice in California. We have a large Japanese population in my community, so we see a lot of NTG. Let's go on to the next slide and chew on this case a little bit. So this is a 69-year-old male, Caucasian, and was referred by his former ophthalmologist for normal tension glaucoma. Now, the funny thing, it says after moving out of town, these are actually real cases that have been adjusted for HIPAA compliance. I don't know if the doctor moved out of the town. I think it's the patient that moved out of town, and the patient's coming to you for your first visit. The patient's been treated with latanoprost and timolol, probably the most common combination of drops utilized today. And the timolol is being dosed in the morning, the latanoprost on label at bedtime. And prior to treatment, we do have some past ocular history available through old chart notes. The Tmax was 18 in the right and 19 in the left. There's some mild nuclear sclerosis. Otherwise, the anterior segment's essentially normal, and some AFib, hypertension, and hypercholesterolemia, not unusual in a 69-year-old male. Concomitant medications include aprobaxin, metropolol, a topical beta blocker, pravastatin, and lisinopril for the elevated cholesterol. Next slide. Here you can see the examination, good acuity. The cataracts are not really bothering the vision yet. Tonometry 16 and 15 with normal pachymetries at 540. The angle is open. It's not open the ciliary body, but it's open the trabecular meshwork with some mild to moderate pigmentation at 1+. And you can see the cup to disc ratio here graded at 0.85 vertically in the right and 0.9 vertically in the left. Let's go one more slide, and then let's take a stop before we hit the punchlines here. So you can see that not only was the cupping significant with those clinical pictures, but you can see both the the T-SNP and GCC depressed here in both eyes. And actually, let's go one more slide, and then we'll stop, and Connie and I will talk about this case. Visual fields are funny, aren't they? You just have this really, essentially generalized depression in the field. And, I'm going to stop here. There was a lot to chew on here, Connie. And I'm going to open it with a question to you, just kind of a history question. 69-year-old person, they have diagnosed NTG. There's an abnormal OCT. It's probably real disease, not just, physiologic cupping. The Packies were normal, pressures in the upper teens, pressures 16 and 15 on TIM and LAT. Maybe just your overall view of this case and your thoughts.
Yeah, some of the things that, just pop out at me as you're going along, like first in the history, the patient's on has a history of hypertension, is on a beta blocker, atenolol, while they're also on timolol and lantanoprost. One wonders, how long has this patient been on the metoprolol? It's possible that he could have been on it long term, and we know that beta blockers systemically can cause the eye pressure to be lower. So this low tension glaucoma, one wonders how much the timolol is really affecting the pressure with a atenolol on board. That's one thing. So where the baseline pressure really is, to me, is a little bit questionable. Now you have these optic nerve photos. How it was recorded, I think it was might have been a record a little bit higher than what I would have recorded for the cup disc ratio vertically. I think it was 0.85 and 0.95, 0.9. I might have recorded it more like 0.8, which might go along a little bit better with the visual fields not being as notable in terms of loss. Although the visual fields are a little wonky, I don't know if I can trust them completely based on how the pattern deviation looks. I do see that this is definitely real disease because the optic nerve cupping correlates with the OCT in terms of areas of loss, both on the retinal nerve fiber layer and the GCC. And so I do think that there's definitely real pathology here. And I do think that because the pressures are already a bit on the low side, but could be lower. One says, okay, is this patient adequately controlled?
Yeah, I mean, there's some really good thoughts there. I'm not a big fan of beta blockers in somebody that has normal tension glaucoma because of its the effect on reducing perfusion pressure. So
Right.
it's not my go-to. And I think we see a lot of generic latanoprost and timolol because it's the easy button. It's not because of they have great efficacy together. I mean, when you look at it, we don't have fixed combination beta blockers, prostaglandins, just because they never met the efficacy bar that the Food and Drug Administration set up. They're available in Europe. They're available in many Asian countries, but we don't have them because of their ineffectiveness relative to each individual component, the bar that the FDA set up. So for me, that wouldn't be a go-to in this patient. It's a great case that our friend Ben Gaddy set in because
Mhm.
it's real world. I mean, the visual fields are completely useless in helping us
Right.
decipher where this patient is on the continuum of the disease.
Mhm.
What I would say, they're 69. They have a 20 or 30-year life expectancy in front of them, even with AFib and elevated cholesterol. So I do think that a management adjustment's an option, and in order. And I would just be curious. I'm going to kind of pinpoint it: Vyzulta, SLT, doing a washout. How would you manage the case like right now, and where specifically would Vyzulta fit in for you?
Yeah, with cases individually based on questions, I would probably dig a little bit deeper. This morning, evening mix is typically, fine. But sometimes there could be adherence issues that are happening here. Maybe the patient actually, when I ask, out of the two medicines, is there any difficulty taking one versus the other? Is a certain time of the day better than the other that you remember more than the other to kind of tease out if they are really consistent with the drop usage that they're using. Sometimes that can help play a role in terms of adherence and how much simpler do I want to make their regimen. Because I know that with my studies and compliance with the Travatan dosing aid, that even sometimes once a day can be difficult. So I'm a big first time SLT user. I offer it very commonly to try to help simplify the regimen even more. And so it wouldn't be abnormal for me to mention considering SLT in this patient. However, knowing what I do know about Vyzulta and having done some studies looking at Vyzulta in both patients who have elevated and low pressures, I know that Vyzulta can work in different populations. And in this scenario, the timolol may not be doing anything. And so being able to go from 2 drops to 1 drop is an improvement in terms of the adherence and compliance ratio. And so that's something that I would also strongly consider.
Yeah, let's go to the next slide. And so this is just that overview of what we described, this patient with relatively low starting pressures. Like Connie said, maybe, because you can miss spikes. And we're setting a 30% reduction in target, which is what our professional organizations, both ophthalmologic as well as optometric professional associations, would suggest as a guideline based on evidence-based medicine. And in this patient, Vyzulta was started. So uh, kind of a very nice streamlining of therapy, right, to reduce compliance issues. So we get rid of that morning drop. And the patient was brought back in approximately a month to see how they were doing. So let's go to the next slide. And here you see a couple of pressure checks, which I think is a very good idea not to assume based on one pressure check, because there might be some compliance kick in there of 16 and 15 in the first visit and 14 and 13 in the second visit. So maybe a little bit of fluctuation depending on what time of the day these pressures were checked. And this is much closer to the target pressure that we were hoping for. So, Connie, any thoughts there before we go to the next case?
Yeah, I mean, I think that the from the initial visit and to the follow-up visit, a couple of points, about 2 points, is something that's very typical for Vyzulta. And when we think about places where we should consider using Vyzulta or where we could, what could be helpful, definitely a switchover is one of them. In the Voyager study, when one looked at name brand Zalatan versus looking also at different levels of lantanopostine Bunad, coming up with a 0.024 for the Vyzulta. When comparing Vyzulta to Zalatan, there was a significant reduction of eye pressure comparatively. And so Vyzulta did work better, likely because of the additional mechanism of action with nitric oxide. And also, when doing post hoc analysis, looking at the differences between the two groups, Vyzulta, there was at least 30% of patients who had at least 3 millimeters of mercury or more compared to the Zalatan group. And there were a number of patients who had several points lower. And so this whole concept of considering a switch over for lantanopros to from lantanopros to Vyzulta is something that is very effective. And we found in our real world experiences that making the switch can sometimes give even up to a 25% reduction in IOP. That's some data that I reported at the AGS meeting. And so I think that when looking at, where can I use Vyzulta, it's good to understand that a switch from other prostaglandin is a very good place to use it.
And also, just for our colleagues, remember the percentage may not be as important, right? Because if you're starting from a higher pressure, your percentage of reduction might be a lot bigger. And
Mhm.
so, absolute IOP reduction, particularly in a normal tension glaucoma patient, might be very important, right? When you're getting down closer to norm to the episcleral venous pressure, to that floor. And there's a great study that was called the Jupiter study showing Vyzulta being very successful in NTG patients. So, with that, why don't we close this? Let's go to the next. Let's go to the next case. And what I'm going to do is I'm going to turn it over to Connie to kind of quarterback us through the case.
Okay, great. So here is a case that we're going to talk about in a patient who has had SLT and looking at different further options after that. Next. So this is a 64-year-old Asian female who presented for a follow-up. She has a history of opening of glaucoma, primary opening of glaucoma, and it's notable that her highest eye pressures in the past have been 28 in the right eye and 24 in the left. Her ocular history is just for the glaucoma and no other medical history, no other medications or any allergies. Next. So here we have her ocular exam, and she sees well in both eyes at 2025 and 2020. Her slit lamp exam is unremarkable. What's notable is that her eye pressures are elevated. So on tonometry, she has a pressure of 28 in the right and 24 in the left. And also what's notable is that she has really thin central corneal thickness at in the 400, so 484 and 482. Uh, Gonioscopy, she's open to a grade 3, and her optic nerves are seen here. I'm just going to pause and just ask you, Jason, from the optic nerves, is there anything that you notice that might be striking, or something that you might just, what strikes you, what you might pick up on here?
Yeah, this is a great case. This is, Manjul Shah shared this case with us, and this is a great case because there's so much to chew on, right? You look at the case and your radar's on saying warning,
Mhm.
because the pressures are so high,
Mhm.
the cornea is pretty thin, the patient basically failed an SLT, which about 10% of people do, or it wore off, one or the other. And then you look at the nerves and you think, okay, this patient's going to have a lot of cupping here. It's going to look really bad. And you look at the cupping and it's like, well, the first thing that comes to my mind is the asymmetry of the nerve itself, assuming that these are done under the same magnification, with that
Mhm.
left eye having a smaller nerve and a tilt on insertion. So a lot going on here.
Right, right. So that's definitely striking. Slightly different sizes and a little bit more cupping, but definitely looking like a nice, healthy rim nerve tissue. Next. So then here you have the OCT. And the OCT, I will say, just upon looking at it, is a little bit different from what I might have expected looking at the nerves. And so we see that there is, in the left eye especially, some loss of some retinal nerve fiber layer. And you can see that in the top right-hand corner looking at the deviation map. And then you're seeing that on the other plots, you're seeing areas of supratemporal loss on the left eye. Not as bad in the right eye, which is the eye that had more cupping. So again, this is a little bit different from what would one expect. Further looking over on the GCC, looking at the macula here, there's definitely more damage on the left side, but there is some damage on the right, and a little bit more noticeable here than looking at the full RNFL. So here you have a patient who has a high eye pressure, has a really thin cornea, has nerves that don't look too bad, but the OCT is showing signs of insult and injury. Next slide. So then here you have the visual field. So then this is where you kind of say, okay, this is really real, okay, because I'm seeing some things here that are correlating, although mild, correlating. So for the right eye, You have a very, borderline superior arcuate, but it does match with the GCC pattern in the inferior temporal area that there was some loss. And then you have on the left eye, the visual field showing an inferior arcuate into a nasal step, which is consistent with what was seen on both the retinal neurofibrillary and the GCC patterns of damage. And so this is a person who has had some kind of insult and injury with those high pressures, which could have been even higher. Although the nerve doesn't match, there's definitely a need for calling this glaucoma and treating. Next slide. So as I stated the case, this is someone who has had this post SLT. So the treatment plan was to do SLT. Now, Jason, is that like if a patient came to you initially, is that the kind of pattern you would have chosen? Do you think you would have started off with SLT, or do you think it would have gone a different direction?
Well, I don't think there's anything wrong with starting off with SLT. If you look at the light study, and now obviously a different population in Europe, it was cost effective and it lowered the pressure as well as our best treatment with the medical wing. Now, of course, in the medical wing in that study, there was no latanoprostene bunad available. So it was latanoprost. And we know, as you described, based on the Voyager study, that Vyzulta is more effective in a subset of individuals. And you also mentioned the study that you did, and I remember early on when this was just getting approved, you talking about that study at a meeting that I was at, and that kind of sub analysis looking at uh, certain patients that had a very significant, not a 1 or 2 millimeter benefit, but a 4 to 5 millimeter benefit. So I'm all about streamlining. I don't think there would be anything wrong with going SLT and then adding in a drop. So I think doctor managed this probably just the way I would have. Just
Yeah,
just unfortunate the SLT didn't work that well.
exactly, exactly. I think that I would have thought the same way because I would have been thinking, oh, I want to try to minimize this patient's use of drops. I would try to see if a SLT would be effective, how much effective, and then get a person off of maybe down to one medicine as opposed to being on two or three. So, yes, it was unfortunate that the SLT didn't work. I agree with the management, but now we're at a situation where the pressure initially was 28 and 24, and then after the SLT was done, the patient's pressures 23 and 26. So still we have real disease, still we have really elevated pressures. And so, as you said, with the different studies, Vyzulta is definitely an option. The real-world study that I had done was a retrospective study. It was a multi-center site. There was 9 different sites, and we looked at 65 eyes or 125 eyes of 65 patients. And we had divided the groups, did a sub-analysis looking at the patients who had pressures that were elevated above 21 and those that were under 21 or below. And what we found was that in the patients that had elevated eye pressures, they had a 41% reduction from mean IOP. And in the lower group, the group that had the lower eye pressure, their mean reduction from baseline was 22%. And so Vyzulta works really well, whether pressures are really high or whether pressures are really low. But interestingly, the catalyst to doing that study was based on a patient who had an elevated pressure. And I remember that case. It was a 44-year-old gentleman who came in with pressures of 34 in one eye and 25 in the other. And he was a busy traveler for his job. He did not want to have a lot of medications. He did have a positive family history for glaucoma. His testing all was aligned with opening glaucoma in the right eye and an ocular hypertension in the left. We decided that we needed to treat both, and we started with the SLT. Now, prior to the SLT, I said, okay, I want to protect your eyes, and I reached out for Vyzulta because I was thinking, I know that this works well as a PGA, but that oxide component is really interesting, and I wonder how it works for this type of patient. We're going to see him back in about a week for the SLT. I'd like to, evaluate this. This is when our Vyzulta was very early, and so he came back, and his pressure had been gone from 34 to 19, and then from 25 to 14. So I knew that there was something very interesting about this Vyzulta in virgin eyes, and that's when the study began. The idea to do the study. So
I think, can I just interrupt? That's a great pearl for our colleagues on the line. And that is when you really want to assess the added benefit of latanoprostene bunad over latanoprost. It's in those early treated eyes where you have somebody that has a relatively functional trabecular meshwork, right?
yeah,
Because although a lot of us aren't driven by mechanism of action, that's where you're really going to be able to assess if there's a relaxation in the trabecular cells and the ability to get that additional outflow. So keep that in mind when initiating it. And that was the jux of Connie's study that I took home. In the early cases, you're going to see potentially this super effect.
yeah, and I think that's a great point, Jason, because when you're going out in the real world and you're like, okay, I want to try Vyzulta. If you're trying Vyzulta and maybe a person who has had advanced glaucoma, has had multiple drops, maybe even other surgeries, and you're trying to make a switch then, you may not see the difference because the trabecular meshwork is not at a maybe state that the nitric oxide can have its most robust effect on. In the earlier to moderate glaucoma cases, I believe that this is really where Vyzulta will have its magic because of the nitric oxide component, exactly what you were saying with the trabecular meshwork. So, getting back to the case, we ended up, this case was treated with Vyzulta, and then they returned for follow up to assess the eye pressure. Next slide. And so you see here, very similarly to my case, we have a patient who started with the pressure 24 and 20, 28 and 24, came down to 23 and 26. And then with adding Vyzulta, the pressures came down to 14 and 16. So this is, again, just a reiteration of these cases that can really have a strong positive effect with a nitric oxide, namely, likely because of not the yes, the uveoscleral pathway and the lanthanoprost acid having its effect there, but then also the nitric oxide component, really a dual mechanism of action that's very powerful. And so this medication was tolerated by the patient, and they were continued on Vyzulta and came back for follow up. Now, Jason, did you have anything else to add that maybe
The,
for
o-
this case
the
or
only thing I would have, first of all, great case, nice presentation. Then I'll turn it over to you to close. Is this is well tolerated. This drop,
Mhm.
when you look at the adverse event profile, when you look at how few people fell out of the Apollo and lunar studies because of adverse events, it was very, very low. So
Mhm.
one of the nice things is you can feel really comfortable that there's going to be a high rate of acceptance of the product
Yes.
from our patients. And I think that's maybe as important as the efficacy
Mhm.
benefits.
Yeah, I know when I think about this whole concept of how compliance and adherence has affected me, I understand that drops have to have a certain number of criteria. They have to work. They have to be something that is well tolerated, like you're saying. It has to be something that is something that's simple enough for them to be able to keep up with. So a simple regimen. Then it has to be something that they can afford. And I can say that with Vyzulta, Vyzulta has gone through some changes over time. I remember when I was using Vyzulta out the gate because I had all these samples and remember how they gave these bottles. It was a 5 ml bottle, so it lasts some time for the patients to be able to come back. And then real world sets in, and then I was, prescribing it, but then I had to have some troubles with prior authorizations and heaviness, and that actually countered me using it as often. But the wonderful, great news is that when you keep using a medication over time, especially if it's a great medication, eventually formulary will catch up. And now Vyzulta is very widely available, so I can consider using it not just as a switchover after someone's already used it as had another prostaglandin. I can now use it as a first line. And so, as I mentioned, there's a lot of personal reasons why and experience why I want to reach for it as a first line, especially in newly diagnosed patients, in addition to switchovers. So it's a great position that Vyzulta is in now for us to be able to adequately use it. I think we'll go to the next slide. So here were just some summaries. Jason went over these slides earlier. Vyzulta is categorized as a PGA. And as a PGA, one has to think about the safety profile in terms of recommending it. So issues surrounding the iris color changes or the lid lash changes, and also whether or not someone has active inflammation. These are things that we all have to continue to think about as we choose our patient selection wisely. Next slide. And then other important safety issues surrounding macular edema and not touching the tip with the lid margin, and contact lens wear, and waiting time in between. So all of those things are important to keep in mind so that as we use the medication appropriately, we can get the best outcomes. And with that, I'll turn it back over to Jason so he can close.
Well, first of all, always a pleasure working with Constance. She is just a wonderful colleague, and so I'm really happy and honored to be with you here. I'd like to thank Bausch& Lomb for sponsoring this. I love these kind of quick hits, right? People can watch them at their convenience, pick up a tip or two, and really kind of focus in on the clinical applications of therapy. So with that, I'd like to thank all of our colleagues that took their time to watch this. I hope it was informational and can be useful in your practice. I'd like to thank Bausch & Lomb for sponsoring it, and I wish everybody health, happiness, and success. Thank you all.
All right. Thank you, Jason. Thanks, everyone.